Picture this scenario. It is like 2 o'clock in the morning.
Yeah.
You're wide awake, the house is completely quiet, and you are staring into the glowing, harsh light of your phone screen.
We have all been there, the classic late-night doom scroll.
Exactly. You've been dealing with some persistent, incredibly uncomfortable physical symptoms, so you did what every single one of us does in that situation. You turned to the internet for answers.
Which is completely understandable, but also a dangerous game.
Oh, a totally dangerous game. You start tumbling down this medical rabbit hole, clicking from forums to medical wikis, and suddenly your heart just drops.
Right.
You're staring at a web page where the words autoimmune disease and cancer are sitting right next to each other in the exact same paragraph.
It is arguably the ultimate recipe for a panic attack. I mean, the sheer volume of medical information available at our fingertips today is staggering.
Yeah, it really is.
But the problem is, when you're reading raw clinical data at 2 a.m. without the necessary medical context to interpret it, it doesn't actually inform you. It just breeds pure, unfiltered anxiety. You see the word cancer, and your brain, understandably, it stops processing anything else.
Which is the entire reason we are here today. For this deep dive, our mission is to take a massive stack of source material. We're talking clinical guidelines, complex systematic reviews, and patient support resources, and unpack them to answer one very specific, often terrifying question for you.
And it's a big one.
It is. Can a skin condition called lichen sclerosus, often abbreviated as LS, turn into cancer?
It's a heavy question, and it carries a lot of emotional weight. But, my goal for this conversation is to establish a calm, deeply analytical baseline.
I love that. No panic, just data.
Right. We are going to separate the nighttime fear from the daytime facts. We'll look under the microscope at the exact biological mechanisms, break down the real-world statistics, and crucially, explore what the latest research proves about how you can prevent it.
And I can promise you, while the premise of this topic sounds incredibly daunting, the actual data we're going to walk through today is empowering.
It really is.
It's about giving you your agency back.
Yeah.
But before we can even begin to understand how LS might interact with cancer pathways, we need to understand what this condition actually is.
Because it is notoriously sneaky.
Right. It operates in the shadows, often going undetected and misdiagnosed for years.
Oh.
So let's establish our baseline. What exactly is lichen sclerosus?
Well, at its core, lichen sclerosus is a chronic inflammatory autoimmune skin condition.
Okay, so the body is fighting itself.
Exactly. When we say autoimmune, we mean your body's immune system, which is supposed to be your defense force against foreign invaders. Like viruses, it gets confused. It mistakenly launches an attack on your own healthy tissue.
And what does that attack actually look like?
The visual hallmarks of this specific attack are these ivory white, shiny, crinkled patches of skin. And these patches undergo a process called atrophy.
Atrophy. So it's shrinking or weakening.
Yeah, that's a clinical term meaning the skin is actively thinning out and losing its structural integrity.
And it targets a very specific area of the body, doesn't it?
It does. I mean, it can theoretically present anywhere on the back, the shoulders, the wrists, but it has a massive predilection for what we call the anogenital region.
So to put that in plain English, it primarily affects the skin around the genitals and the anus.
Yes. In women, these white, thinning patches frequently form a very distinct figure-of-8 pattern that circles those specific areas.
Let's look at who actually develops this, because the demographic data in our sources completely upended what I thought I knew. I kept seeing the phrase bimodal distribution in the older literature.
Yeah. That bimodal concept is a fascinating piece of medical history.
How so?
Well, for decades, the prevailing wisdom in the medical community was that LS struck at two very distinct, separate phases of a female's life.
Like it skipped the middle.
Exactly. They believed it peaked first in pre-pubertal girls, kind of went dormant, and then peaked again in postmenopausal women. The assumption was that women in their reproductive years were largely spared.
Right. Possibly due to the protective effects of estrogen, I think I read.
That was the theory, yes.
But the more recent data we have essentially sets that old assumption on fire. One of the comprehensive studies in our stack shows that up to 40% of women with the condition actually display symptoms right in the middle of their reproductive years.
Yep.
That's nearly half the patient population. It completely shatters the narrative that this is only a childhood or postmenopausal issue.
The clinical data definitely forces a rewrite of those old textbooks. And we also need to be clear that while it is vastly more common in females, with estimates ranging from a 3-to-1 to a 10-to-1 ratio compared to men, it absolutely affects men as well.
Okay, so how does it present in men?
In male patients, it almost exclusively presents on the foreskin and the glands of the penis, and it is seen predominantly in men who are uncircumcised.
The symptoms described in these patient resources are just brutal. They're not subtle in the slightest.
No, they're incredibly severe.
We are talking about intense, relentless itching that keeps people awake all night, severe soreness, dyspareunia, which is the medical term for severe pain during intercourse, the skin actually physically tearing because it's become so paper thin.
It's awful.
And if it goes on long enough, it causes severe structural changes to the anatomy. In women, that means the physical fusion of the labia, where the skin heals together. In men, it causes phimosis, which is a severe, restrictive tightening of the foreskin.
The architectural destruction of the tissue can be profound, and unfortunately, it is often permanent if the inflammation isn't stopped, which makes the diagnostic data we reviewed so incredibly frustrating to read.
Frustrating is putting it mildly.
One of the survey studies highlighted a truly devastating statistic. For premenopausal women, the average delay in getting a correct diagnosis is 4 years. 4 years from the onset of these agonizing symptoms to simply getting the correct name for the disease.
Okay, I have to stop us here and really push back on this because reading that statistic made me genuinely angry. If the symptoms are as severe as physical tearing, structural fusion, and agonizing pain, how in the world does a patient sit in a doctor's office and get dismissed for 4 entire years?
You're touching on one of the most systemic failures in primary care regarding vulvar health. It basically comes down to a perfect storm of clinical blind spots.
Like what?
First, because of that outdated bimodal assumption we just discussed, many primary care physicians simply aren't trained to look for LS in a 30-year-old woman. They don't expect it, so they just don't see it.
That is wild.
Second, while the end-stage structural changes are obvious, the early symptoms, the itching, burning, and soreness, are incredibly nonspecific.
Okay, so it looks like a lot of other things at first.
Exactly. When a patient presents with those complaints, a busy doctor in a 15-minute appointment makes the most statistically common assumption. They diagnose a routine yeast infection, also known as thrush, or perhaps attribute it to early hormonal changes.
So the patient gets sent home with a generic, over-the-counter antifungal cream. A cream that does absolutely nothing to stop an internal autoimmune attack.
Right. It does nothing.
They use it, it fails, they go back, they get another cream, and the cycle just repeats for 48 months while the skin continues to deteriorate.
The literature explicitly notes that there are virtually no standardized diagnostic decision aids in primary care to help general practitioners easily delineate this specific autoimmune skin disease from a common fungal infection.
That's a huge problem.
Unless the doctor has specialized training in vulvar dermatology, the patient is left in a diagnostic loop and the chronic damage continues unchecked.
Well, let's follow that chronic damage because that timeline leads us directly to the core anxiety of our deep dive. You have a patient whose skin is being relentlessly attacked by their own immune system for years. The tissue is thinning, tearing, trying to heal, and tearing again. The ultimate question you're left with at 2 a.m. is, does all that constant chronic cellular destruction eventually cause the cells to break so completely that they turn into cancer?
The straightforward biological answer is yes, it can. But we need to put an immediate, massive spotlight on the context here. While the mechanism exists, the overall statistical risk is relatively low.
I want to make sure we give you the exact numbers so we aren't dealing in vague, abstract fears. I combed through the systematic reviews, and the data is very consistent.
It is. When you aggregate the studies, the risk for women with vulvar LS developing vulvar cancer, specifically a type called squamous cell carcinoma, or SCC, sits around 3.5 to 5%.
Okay.
There are a few isolated estimates that push closer to 6.7%, but realistically, we are talking about roughly 4 out of every 100 people. For men, the risk of penile cancer from LS is nearly identical, hovering right around that 4 to 5% mark.
So we have a roughly 4% risk. Let's flip that around to highlight the positive. That means 96% of people with lichen sclerosus will never develop cancer from it. But for the 4% who unfortunately do, we need to look at how it happens. Because while reading through the oncology sources, I found an incredible aha moment. It turns out there are 2 completely different, distinct pathways to developing vulvar cancer.
This is one of the most critical distinctions in modern gynecological oncology. Historically, when the general public or even many doctors think of cervical or vulvar cancers, the immediate association is HPV, the human papillomavirus.
Right.
That virus is pathway 1. HPV-associated cancer usually affects younger demographics and is linked to a precursor lesion called UVIN. That acronym stands for usual type vulvar intraepithelial neoplasia.
Okay, let's translate that out of medical Latin for a second.
Yep.
Scroepithelial just means it's happening inside the top outer layer of the skin.
Correct.
And neoplasia simply means a new abnormal growth of cells. So UVN is a patch of abnormal cells brewing right at the surface, caused by the HPV virus.
That's a perfect breakdown. But lichen sclerosus operates entirely outside of that virus. It uses pathway 2.
The HPV-independent pathway?
Exactly. It generally presents in older patients, and it's linked to a completely different, much stealthier precursor called DVIN differentiated type VIN.
So think of it like this. If vulvar cancer is a final destination, you can drive there on 2 different highways. Highway A is paved by the HPV virus, but Highway B is paved by the chronic inflammation of autoimmune conditions like lichen sclerosus.
I like that analogy.
Thanks. They are completely different roads built by different mechanisms that ultimately lead to the exact same bad destination.
The clinical data backs up that analogy perfectly, and we have to pay very close attention to Highway B. Even though DVIN, that specific precursor linked to lichen sclerosus, represents less than 10% of all vulvar precursor diagnoses, it punches way above its weight class in terms of danger.
It's aggressive.
It is highly, highly aggressive.
I was looking at the comparison study in our sources,
Yeah.
and the difference in speed between those 2 highways is staggering. They measured the 10-year cumulative cancer risk.
Yeah.
For the HPV-related precursor, the risk of it turning into invasive cancer over a decade was 9.7%.
Right.
But for DVIN, the lichen sclerosus precursor, the 10-year risk was 50%. Half of those lesions aggressively progressed to cancer.
The speed limit on Highway B is terrifyingly fast once you're on it. Pathologists struggle with it because DVIN can visually mimic normal inflammation under a microscope, making it really hard to catch before it accelerates.
But wait, if DVIN is moving that fast and is that aggressive, what is happening inside those cells that makes them so much more chaotic than the cells on the HPV road? Like, how exactly does chronic itching and inflammation turn a benign skin condition into a malignant tumor?
To truly understand that, we have to zoom way in. We need to look at the microscopic pathogenesis, the literal step-by-step biological domino effect of what happens when LS goes untreated.
Okay, take us through the dominoes.
When the immune system sets up camp in the genital tissue and mistakenly attacks, it creates a localized state of constant, unrelenting inflammation. And that chronic inflammation generates a toxic byproduct known as oxidative stress.
Oxidative stress is one of those buzzwords you hear in high-end skincare commercials about fighting wrinkles. But what does it actually mean in the context of an autoimmune disease?
Let's strip away the marketing jargon. Your cells require oxygen to function properly. But when immune cells flood an area to fight a perceived threat, they release chemical weapons.
Sounds intense.
It is. These chemicals create unstable oxygen molecules called free radicals. When you have a chronic condition like LS, these free radicals wildly outnumber your body's natural antioxidant defenses. That severe imbalance is oxidative stress.
So what do these free radicals do?
These unstable molecules are destructive. They immediately trigger a process called lipid peroxidation.
Oh, let's break that one down too. Lipids are essentially the fats that make up the protective outer membrane, the wall, of every single cell in your body.
Yes.
So lipid peroxidation means those unstable molecules are literally breaking down the structural walls of the skin cells.
Precisely. The chronic inflammation is essentially rusting the cells from the outside in. And if that rusting process goes on long enough, it eventually breaches the core of the cell, penetrating the nucleus.
And the nucleus is where the DNA is.
Exactly. This is where it causes actual physical oxidative DNA damage within the dermal sclerosis, which is the thickened, scarred skin characteristic of late-stage LS.
And once you start damaging the DNA blueprint, that is where the cellular machinery completely derails.
Because this oxidative damage doesn't just randomly hit unimportant parts of the DNA, it has a devastating impact on specific tumor-suppressing genes. The most crucial one identified in our oncology sources is the TP53 gene.
TP53, what does that do?
In a healthy body, TP53 is the absolute guardian of your genome. It meticulously regulates cell division and forcefully stops abnormal mutated cells from multiplying. But the constant tissue damage and oxidative rusting from untreated LS downregulates the TP53 gene. It essentially forces it to power down.
Wow. It's exactly like the TP53 gene is the brake pedal in a car. The oxidative stress from the untreated, rampant inflammation sneaks in and physically cuts the brake lines.
That's exactly what's happening.
Once the brakes are gone, There's nothing to regulate the speed. The damaged cells just start dividing uncontrollably, accelerating faster and faster until they crash right into squamous cell carcinoma.
That mechanical failure is the exact pathogenesis of how the cancer forms. In fact, when pathologists analyze biopsies of that dangerous DVAN precursor, the primary hallmark they look for is the presence of a mutated p53 gene.
That's how they know it's DVAN.
Yes, it proves the brake pedal is definitively broken. The immune system's misguided attack causes the inflammation. The inflammation causes the oxidative stress. The oxidative stress mutates the tumor-suppressing gene, and the loss of that gene allows the cancer to freely grow.
It's an intimidating biological reality. The idea that your own immune system's friendly fire is what cuts the brake lines on your cellular division. But here's where we pivot the entire conversation.
Yes, to the good news.
Because after exploring the very real biology of how this nightmare happens, we get to the empowering reality of the solution. We know exactly how to fix the brakes.
We do. And it is crucial that the narrative around lichen sclerosus shifts from inevitable cancer to actionable control. Because the medical intervention we have to prevent LS from progressing to DVAN and ultimately to cancer isn't just a theory. It is a highly effective, proven cornerstone of treatment.
And that treatment relies entirely on ultra-potent topical corticosteroids. The specific medication heavily cited in the guidelines is clobetasol propionate.
We need to be clear about what this medication is. These are not the standard 1% hydrocortisone creams you buy over the counter for a mild mosquito bite.
Definitely not.
These are ultra-potent prescription-strength steroids engineered to forcefully intervene at the cellular level.
Let's explain how they intervene, because we know the problem is the immune system flooding the area with inflammatory chemicals. How do the steroids stop that?
Corticosteroids are essentially master messenger molecules. When you apply them to the affected skin, they easily slip through that lipid wall of the cell we talked about earlier.
So they get inside.
They travel straight into the cell's nucleus, interact directly with the DNA, and literally flip the switches off on the specific genes that are commanding the immune cells to produce those inflammatory chemicals.
That is amazing.
They shut down the localized attack at the genetic source. And the clinical data on how well this protects the patient is just astounding.
I want to highlight the Lee, Bradford, and Fisher study here. I was reading through the systematic review, and when I hit the conclusion of this specific trial, I actually had to stop and read it twice to make sure I understood the numbers correctly.
Oh, it is considered a landmark longitudinal study in this specific field. The researchers followed a large cohort, 507 individuals, diagnosed with vulvar lichen sclerosus over a significant 6-year period.
That's a huge study.
It is. They divided these patients into 2 distinct observational groups. The first group consisted of patients who were strictly compliant. They consistently used their prescribed steroid therapy exactly as directed.
And the second group?
The second group consisted of patients who were non-compliant. They were inconsistent, stopped using it when they felt better, or just refused the steroids altogether.
And the results of that 6-year observation. For the 70.4% of patients who consistently used their steroid maintenance therapy, out of that entire group, they recorded exactly 0 cases of vulvar cancer. Not a single one.
0 cases in a population that we know carries an elevated baseline risk. Consistent, appropriate treatment essentially neutralized the oncological threat entirely.
That is incredible. And what about the non-compliant group?
Conversely, when they looked at the 29.6% of patients who were non-compliant with the steroid protocol, they found 7 cases of vulvar cancer developed during that same time frame.
That is the ultimate definition of empowering data. The medicine works. It stops the immune system's attack, which stops the oxidative stress, which protects the TP53 gene, which keeps the brakes firmly applied to the cells.
Exactly. And for a complete picture, we should briefly touch on the male patient population.
Oh, right. What's the protocol there?
For men and boys who present with LS specifically isolated to the foreskin, the urological guidelines strongly suggest that early circumcision is often entirely curative.
Oh, wow. Curative.
Yes, because the autoimmune process is so intensely localized to that specific piece of tissue, surgically removing it effectively cures the condition and completely removes the associated cancer risk.
But for women, surgical removal of the affected tissue isn't an option. The steroids act as an ongoing invisible shield. Which brings us to the most common practical question I guarantee someone listening to this right now is asking.
Let's hear it.
Let's say you get the correct diagnosis. You use this ultra-potent clobetasol, the agonizing itching finally stops, the skin stops tearing, and visually, everything looks completely normal again. Are you cured? Can you toss the tube of cream in the trash?
That is the most common pitfall in managing this disease, and falling into that trap is incredibly dangerous. No, you absolutely cannot throw the medication away.
Not even if you feel 100% better.
Nope. Lichen sclerosus is a chronic, lifelong autoimmune disease. The steroid cream does not cure the underlying confusion in your immune system. It merely suppresses the localized inflammation it causes.
So if you stop using it,
If you withdraw the medication entirely, the immune system will inevitably resume the attack. The inflammation will return, often quietly at first, silently creating that oxidative stress long before you feel the itching again. The medical consensus is absolute here. The steroids must be utilized as a lifelong, proactive maintenance therapy.
so you have to treat it exactly the same way you treat brushing your teeth. You don't stop brushing your teeth just because you don't happen to have a cavity today. It is daily maintenance to prevent the decay.
That is the perfect mindset to have. And alongside the lifelong medication protocol, the medical sources heavily emphasize a secondary line of defense: strict, routine self-monitoring. Patients are strongly encouraged to examine their vulvar or penile skin thoroughly every single month.
The guidelines are very practical about this. They suggest getting a good hand mirror, sitting in a well-lit room, and getting intimately familiar with what your baseline, quote-unquote, normal skin looks like while on treatment.
Right, because you need to be able to immediately spot the red flags.
And you aren't just looking for general mild redness.
Yeah.
The red flags for that dangerous DVIN precursor are very specific physical changes.
Yes, you are looking for nodules, which present as hard, distinct, raised lumps under the skin. You are monitoring for persistent fissures. These are tiny cuts or linear tears in the skin that just stubbornly refuse to heal even after several weeks of steroid use.
What else?
You're looking for a clinical symptom called hyperkeratosis, which presents as new, thick, leathery, raised plaques of skin. And obviously, you're looking for any open ulcers or sores that won't close up.
If you see any of those specific changes, you do not wait 6 months for your annual checkup. You pick up the phone and call your specialist immediately.
Without hesitation, because, as we highlighted earlier, if those changes do happen to represent DVIN, the timeline for progression is aggressive. This is also why establishing a relationship with a clinical expert for regular follow-ups every 6 to 12 months is vital.
Because it's hard to catch.
Right. As we noted, DVIN is incredibly difficult to diagnose. You need a specialist who knows your specific medical history, who has tracked your baseline, and who has the trained eye to spot the microscopic changes that warrant a punch biopsy.
So let's pull all of these threads together. If you are sitting there right now, overwhelmed by the medical jargon, the daunting statistics, and the sheer terror of what you found on the internet at 2 a.m., what is the ultimate takeaway?
The takeaway is control.
Exactly.
Yeah.
Yes, lichen sclerosus can turn into cancer. That is a biological mechanism that exists. But knowledge is your absolute greatest weapon here. The actual statistical risk is remarkably low, around 4%.
Very low.
And even that small risk is heavily, almost entirely, mitigated by consistent lifelong treatment with topical steroids and regular routine self-checks. This is not a story about an inevitable tragedy.
Right, not at all.
It's a story about empowerment and taking agency over your own biology. You have the medical tool to protect your TP53 gene, keep the structural brakes on your cells, and keep the dangerous inflammation completely shut down. It is entirely about taking control, not succumbing to the panic.
You know, looking at all this data, it leaves you with a fascinating question about the future of medicine. Right now, our most effective weapon is a blunt instrument.
Oh, yeah.
We use potent steroids to basically shout down the immune system and force it into submission.
Yeah, we're just suppressing it.
But scientists are already exploring a different frontier. What if the future of preventing these autoimmune-driven cancers isn't about constant suppression? What if it's about retraining?
Oh, wow. Retraining the immune system.
Yeah. They are actively looking at how to wipe the immune system's localized cellular memory, teaching it to permanently forget that the skin was ever considered an enemy. Consider the profound irony here. The immune system is designed to protect you from threats like cancer.
Right.
Yet in LS, the immune system mistakenly attacks healthy tissue, and it is the exhaustion from that relentless, misguided attack that ultimately opens the back door for cancer to slip in. It makes you wonder how much of disease prevention isn't about fighting off external invaders, but simply helping the body make peace with itself.
That is a profound thought to end on. Helping the body make permanent peace with itself. Because the next time you find yourself awake at 2 a.m., tumbling down a medical rabbit hole, staring at terrifying words on a glowing screen, remember this: The internet algorithms will always push you toward the worst-case scenario. But the actual science, the hard clinical data, it gives you the map, it gives you the tools, and it gives you the power to write a completely different ending.